Okay, we're now going to talk about brainstem, cranial nerve, motor nuclei. We're going to answer the question, what are the locations, functions, and clinical implications of the brainstem, cranial nerve, motor nuclei? Hello everyone, my name is Dr. Morton, and I'm the noted anatomist. Okay, so the objectives, we're going to identify, describe the topography, modality, associated cranial nerve, and function for each of the following cranial nerve motor nuclei. Somatic motor nuclei, those 4 nuclei. Visceral motor nuclei and those 4 nuclei, and branchial motor nuclei and those 3. And we'll talk about each one of these. And so in identifying the location of cranial nerve nuclei, here's a few things to keep in mind. What level of the brainstem is it? So every time we're going to cover a nucleus, we're going to look at a level of the brainstem and say, what level is it and how do you know? Where's the water? Meaning, where's the ventricular system in the CSF? Where's the sulcus limitans? If we can find the sulcus limitans, if a nucleus is medial to the sulcus limitans, we're talking about a motor nucleus. If it's lateral to the sulcus limitans, we're talking about a cranial nerve sensory nucleus. So there's some background. So the first one we're going to start with is somatic motor neurons. And those 4 somatic motor neurons are found in the midbrain, pons, and medulla. And so somatic motor neuron nuclei are homologous to the ventral horn and the spinal cord, and they're located medial to the sulcus limitans, adjacent the midline. So we take a look at a schematic of the midbrain, pons, and medulla in cross section. There we can see 3 of those somatic motor nuclei and look at them. They're medial to the sulcus limitans right by the midline. Okay, so here on the left is a schematic of showing a coronal section through the brainstem, and there we have listed in that vertical column all the somatic motor nuclei. And we're going to start with the oculomotor nucleus in the rostral midbrain in this mid-sagittal section right through there. So this is what it looks like. This is the midbrain. We can tell from the cerebral peduncles, the red nucleus, and substantia nigra. So let's find the water. There it is. We call that the cerebral aqueduct. Now let's find the sulcus limitans. Shing! It's right there. And so if we're going to be medial to the sulcus limitans near the midline, there's our nucleus. And this is called the oculomotor nucleus, and it's associated with cranial nerve 3, the oculomotor nerve. And those axons course through the ventrally, right through the red nucleus and out the ventral surface of the midbrain, en route to extraocular muscles. And so the oculomotor nucleus innervates all extraocular muscles except our superior oblique and lateral rectus. And so here in this picture, we can see cranial nerve 3 exiting the ventral surface of the midbrain, and it's transporting axons from the oculomotor nucleus. And then there the arrow is showing this oculomotor nerve is branching out to these extraocular muscles, like our levator palpebrae superioris, keeps your eyelid up. Superior rectus helps you to look up. Medial rectus helps you to look in or adduct the eye. And inferior oblique and inferior rectus muscles help you to move your eyeball down or to look down. And so now, how do we examine or test the oculomotor nucleus? So this is accomplished by examining the extraocular muscles, our superior rectus, medial rectus, inferior rectus, and inferior oblique. And how do we test that? Well, we take a look at a patient and identify or take a look at one eye, and we do the H pattern. And this H pattern, we're going to be able to test these muscles. So superior rectus, inferior oblique, and medial rectus. But another way of determining how well the oculomotor nucleus is functioning is to take a look at the muscles it doesn't innervate, like the lateral rectus does not innervate that, or the superior oblique. Lateral rectus abducts the eye, superior oblique helps your eye to depress. So that if we have a damage to the oculomotor nucleus, we're going to see that the eye is going to deviate down and out like this. Shing! One more time. So we damage the nucleus. Shing! The eye is down and out. So the eye is deviated down and out due to unimposed action of the lateral rectus and superior oblique muscles. And lack of innervation to the levator palpebrae superioris results in ptosis. So even if you lift up the eyelid, you can see that the eye is deviated down and out. So we've just finished the oculomotor nucleus. Now let's go to the caudal midbrain, where the trochlear nucleus is located. And we see now that line in the mid-sagittal section of the brain is through the inferior colliculus. Here we have the trochlear nucleus. It's located in the caudal midbrain at the level of the inferior colliculus. So we find our cerebral aqueduct, or where the cerebral spinal fluid is. And then we find our sulcus limitans. We're going to be medial to that right by the midline. Shing! There it is. That's our trochlear nucleus. Now, this is associated with cranial nerve number 4, or your trochlear nerve. And the axons decussate to the contralateral side before exiting. So there's our axon coming out. And notice that the axon courses behind the cerebral aqueduct, and it exits on the contralateral side of the midbrain and then wraps around the cerebral peduncle en route to the superior oblique muscle. And so if there's injury of the trochlear nucleus, as that red X demonstrates, this produces a deficit in the contralateral superior oblique muscle. Whereas injury of the trochlear nerve produces a deficit in the ipsilateral superior oblique muscle. The nice thing is, I don't think anywhere you're going to be tested on, well, I'm saying this as if everyone's a med student, but this is a concept where rarely are you isolate, where you have to determine which side a lesion is for trochlear nerve or nucleus. Now, the trochlear nucleus innervates the superior oblique muscle. So in this lateral view of the orbit, the arrow shows that the trochlear nerve exits on the back side or dorsal surface of the midbrain and courses around the cerebral around the cerebral peduncles and then into the orbit. And their SO for superior oblique is the muscle, the only muscle, the trochlear nerve innervates. And that green structure is called the trochlea, which means pulley, because that's where the superior oblique wraps around to the back of the eyeball, hence the name of the nerve innervating this muscle and its associated nucleus, trochlear nucleus and nerve. So how do we test the trochlear nucleus? We do this by testing the superior oblique muscle. And how do we test that? By looking medially and down. So again, we isolate one eye. We're going to, in this case, do the right eye. And we put the H pattern. And we have the patient look medially and down. Medially because it isolates the superior oblique from the inferior rectus. And then down because it's the only muscle in that position that'll test the downward, looking in downward gaze. So we've now covered the trochlear nucleus. So we're now going to go down to the next one, which is the abducens nucleus, and we notice there's a cross-section now through the pons and the mid-pons. The abducens nucleus is located in the pons. Let's find the water. There's our fourth ventricle. And let's find the sulcus limitans, which is there. And then let's find a nucleus that's medial to that near the midline. Shing! There it is. That's our abducens nucleus, which is associated with cranial nerve 6, which is known as your abducens nerve, going by the same name. And the axon courses out ventrally through the front of the brainstem en route to one muscle, the lateral rectus muscle. So in this, again, lateral view of the orbit from the left side, the lateral rectus muscle is shown in orange. And so and in my illustration here, it's been cut, so I'm just going to put them together like this. That's what the lateral rectus looks out. And to test it, we have the patient look out. So how does that work? So here's we have, again, a patient looking forward, and we isolate the right eye, and we just have a patient abduct the eye, and that tests the lateral rectus muscle, hence the name abducens nerve and nucleus, to abduct the eye. So in a normal position, when there are patients looking forward, again, focusing the right eye, the right abducens nucleus and nerve should have the eye do this, tracking your finger as we go laterally. The lateral rectus abducts the right eye. Now, injury to the right abducens nerve is going to result in double vision when looking laterally to the side of the lesion. So here we have the patient looking forward, and then when we try to have the patient track the finger going to the side, that right eye is unable to do it because the lateral rectus is unable to abduct the right eye. This results in double vision when looking right. What about injury to the right abducens nucleus? This results in an inability to look laterally with either eye to the side of the lesion. This is due to the MLF, which is the medial longitudinal fasciculus. This is something to learn about later on. And so here we've got the eye looking forward, and if it's the right abducens nucleus that's injured, likely the patient's unable to look right with either eye because of injury to the abducens nucleus, which affects the MLF system. The MLF system helps coordinate the oculomotor, abducens, and trochlear nuclei to coordinate a bilateral gaze. So we just finished the abducens nucleus. Now let's go down that elevator shaft down in the brainstem to the medulla to the hypoglossal nucleus. And we can see the cross section is through the green part of the brainstem where the medulla is. And this hypoglossal nucleus is tall. It's tall and thin. It spans almost the entire length of the medulla. But in cross section, here's our medulla, and we find the water. There's our fourth ventricle. Then we find the sulcus limitans, shing, and we're medial to that by the midline. And there we have it. There's our hypoglossal nucleus. This nucleus is associated with cranial nerve number 12, the hypoglossal nerve, which innervates tongue muscles. And so tongue muscles, the nerve exits ventrally right between the pyramid and the olive. That's a great way to find the external exit of the hypoglossal nerve. So the hypoglossal nucleus innervates all these tongue muscles, but a big one is the genioglossus muscle, which is responsible for protruding the tongue out of the mouth. So here's a mid-sagittal section through the oral cavity, and there is our genioglossus muscle. Genio means chin, glossus means tongue, and this, when it contracts, takes the tongue and sticks it out of your mouth as in na, 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 like that. Okay, so here's a superior view that shows both genioglossus muscles, and when they contract bilaterally, they have a vector pull that comes from a lateral to medial direction, and then if you put those vectors together, it causes the tongue to protrude out of the mouth. And so injury to the hypoglossal nucleus or injury to the hypoglossal nerve produces a deficit when protruding the tongue. So the protruded tongue deviates to the side of the lesion. So here is normally, if we then knock out, even though that whatever that symbol that's like, hey, something's bad here, is showing the muscle, it's because the muscle can't contract because of the hypoglossal nucleus or nerve that are damaged. And what happens then is the vector results in going towards the side of the lesion. So the protruded tongue deviates to the side of the lesion, hence the term lick your wounds with regards to injury to the hypoglossal nucleus or nerve. So that is showing all the somatic motor neurons and nuclei. Basically, somatic motor nuclei deal with eye muscles and tongue muscles. There you've got it. Okay, so next we're going to go over visceral motor neurons. And visceral motor neurons and their associated nuclei are in the midbrain, pons and medulla, Ettinger-Westphal, superior salivatory, dorsal vagal, and inferior salivatory nuclei. So these are homologous to the lateral horn in the spinal cord gray matter, and their location is they're medial to the sulcus limitans, but they're medial and adjacent the sulcus limitans. They're closer to that. And so here we have a cross-section through these different parts of the brainstem, and we can see 3 of those visceral motor neurons, and watch, shing, going right down, is medial to the sulcus limitans, but they're adjacent the sulcus limitans. And so here is a coronal section through the brainstem, and we can see the vertical columns of visceral motor nuclei, and the first one we're going to talk about is the Ettinger-Westphal nucleus, located right through there, through the rostral midbrain at the level of the superior colliculus. So here we have that cross section of the midbrain, and how do we find the Ettinger-Westphal nucleus? We find the water, cerebral aqueduct, find the sulcus limitans, shing, and it's medial to that, and there's our Ettinger-Westphal nucleus, also known as your accessory oculomotor nucleus. This is associated with cranial nerve number 3, and the axons course through the red nucleus and exit ventrally, and then once they exit, those axons are in the same epineurial sheath as the somatic motor nuclei, axons coming from the ocular motor nucleus. In this lateral view of the orbit, we're going to then trace this out. So the Ettinger-Westphal nucleus is there, and the axon is going to course ventrally as the arrow points, and then the synapse is going to occur in the ciliary ganglion. And at that, the postganglionic parasympathetic neurons course out, and they course to innervate 2 different structures. One, the pupillary constrictor muscle that causes pupil constriction, and ciliary muscles that does the lens accommodation. Let's do ciliary muscles first. And so here we have a longitudinal section through the front of the orbit, and the ciliary muscles are there in orange. And so it's hard to see it, but they're wrapping all around a circumference. So all we see is the top and bottom part. And their function is they're going to help act on the lens, or to help change the shape of the lens, which is identified simplified there. And the ciliary muscles are attached to the lens by the suspensory ligaments. And so what happens is, in this position, the ciliary muscles are relaxed. And as a result, the suspensory ligaments are tight, and those pulling tight of those ligaments causes the lens to be more flat than it usually is. But what happens then is if we have the Edinger-Westphal nucleus that sends a message through the oculomotor nerve, cranial nerve 3, and goes shing, and it then innervates the ciliary muscles. As with all these muscles that have a circular pattern, the circle gets smaller. So watch, shing, and watch what happens then. The distance between the top and bottom portion of the ciliary muscles gets smaller. And so what happens is when the ciliary muscles contract, the suspensory ligaments become loose, and the lens goes back to its more natural shape, which is oval. Now, why do we want that to happen? Well, this is where the lens accommodation happens in dealing with near vision. So here's the eyeball looking at something in a distance. Hey, what is that? So the light from that picture of the woman doing a headstand, the light's traveling from a distance and therefore needs less refraction to focus on the retina because the light is in a parallel fashion like this, and then it refracts to focus on the lens, on the retina. However, in here, if you're now looking something very close, like the phone in your hand, the light traveling from a point very close needs more refraction to focus on the retina. So watch, comes in and more refraction. And so the lens needs to change shape. So watch, this picture at the top will show this. When you're looking from a distance, the ciliary muscles are relaxed, but when you look close, that's when you need contraction of the ciliary muscles to make the lens become more fat. And since cranial nerve 3 causes this lens to accommodate. Now, the pupillary sphincter muscle is what causes your pupil to constrict. And so one way of testing the Edinger-Westphal nucleus is the pupillary light reflex. So here we have a pen light, and when you shine the light, shing, you're going to see the pupils dilate. Pardon me, let me say that again. When you shine the light, you're going to see the pupils constrict. Now, if you have an injury to the Edinger-Westphal nucleus, it causes mydriasis, which is the fancy term for an excessively dilated pupil. So here, what happens if we damage the Edinger-Westphal nucleus, and usually if you damage that nucleus, you're going to damage often the adjacent oculomotor nucleus. Look, there's mydriasis. That pupil is dilated. You can see it better if we lift up that eyelid. You can see the pupil is much more dilated on the right, where the nucleus is injured, when compared to the left, the normal side. So there's the Edinger-Westphal nucleus. Now let's descend down into the pons and talk about the superior salivatory nucleus. So the cross section you can see is near the bottom of the pons. So the superior salivatory nucleus is located in the pons, and we find the water. There's our fourth ventricle. We find the sulcus limitans. Shing, it's right there. And so we're now going to look for a nucleus that is medial to the sulcus limitans, but adjacent to it. And there it is. There's our superior salivatory nucleus. This is associated with cranial nerve number 7, our facial nerve. And this nucleus gives rise to parasympathetic innervation, or preganglionic parasympathetic neurons, and innervates the salivary, lacrimal, and nasopalatal glands. But this nucleus gives rise to axons that course to these glands via 2 different nerve branches in the facial nerve. There's the axon exiting out the side of the pons. Okay, so in this schematic, to the green circle and the yellow arrow showing the superior salivatory nucleus. Now, one of the branches that axons from the superior salivatory nucleus are going to follow is called the chordotympany nerve. So we see that yellow arrow goes shing through the internal acoustic meatus into the petrous part of the temporal bone, and then the yellow arrow shows there the chordotympanic branch from the facial nerve. It's called that because it makes a chord along the tympanic membrane, and then it courses into the infratemporal fossa and hitchhikes on the lingual nerve branch of V3, the mandibular branch of the trigeminal nerve. And there we have a synapse that happens in that submandibular ganglion, which I didn't, I'm sorry that I didn't label it, but that's where the submandibular ganglion is. And then the postganglionic neurons go and innervate sublingual and submandibular salivary glands and make saliva. Now, this other nerve that superior salivatory nucleus axons go to is through the greater petrosal nerve. So we follow the cranial nerve 7 in through the internal acoustic meatus, and then another branch is called the greater petrosal nerve. And that greater petrosal nerve is going to enter the pterygopalatine fossa, and then right here, and I didn't do this as well, label that's where our pterygopalatine ganglion is, where the synapse occurs. But then the postganglionic parasympathetic neurons are going to go out and innervate the nasopalatine glands, making mucus in your nose and palate. And then another branch hitchhikes on V2 and goes up to the lacrimal gland and makes tears. So there's the greater petrosal nerve. So an injury to the superior salivatory nucleus gives a lot of dry stuff, like a dry mouth, because you don't have submandibular and sublingual salivary gland function, and a dry eye because the lacrimal gland is not functioning, and dry mucous membranes on that side because the nasopalatal glands are not functioning. All right, so there is our superior salivatory nucleus. Now let's go down and go into the medulla and talk about the inferior salivatory and dorsal vagal nuclei, both of those. So here's a cross-section of the medulla, and let's find the water. Shing, there's our fourth ventricle filled with CSF. We find that, look for the sulcus limitans there, and now we're going to look medial to the sulcus limitans, but adjacent that imaginary line. And shing, there's our dorsal vagal nucleus. This is associated with cranial nerve number 10. As a matter of fact, this is what the vagus nerve is the principal parasympathetic nerve in the body, and this is where the parasympathetic fibers arise. This is where the preganglionic parasympathetic fibers arise that innervates the heart, the lungs, foregut and foregut organs, and midgut. That's where it all arises. Now, if we knock out this nucleus, we do not really see that much of an effect, primarily because those, like especially with foregut and midgut, they function on their own, and that you have the other side so that the heart and lungs has duly innervated for parasympathetic, and a lot of other circulating hormones help. So really you don't see too much of a difference if you knock out that dorsal vagal nucleus in the function of the vagus nerve. Oh, there it is. There's the axon coming out laterally from the medulla. Now, the inferior salivatory nucleus is just adjacent to the dorsal vagal nucleus. It's also in this medulla, and it's very tiny, and I could never distinguish it in a cross-section of fresh brainstem. I'd never be able to identify it, or I just looks right along there. And its function is it's associated with cranial nerve 9, glossal pharyngeal nerve, and that's what provides innervation to the parotid gland to make saliva. But because the parotid gland only makes a small fraction of the saliva, if it's knocked out, most likely there will be no change in the amount of saliva made in the mouth. Okay, now to the third type of motor nuclei called branchial motor neurons. And these are found not in the midbrain, but only in the pons, where there's 2, trigeminal and facial motor, and the medulla, nucleus ambiguus. And so branchial motor neurons are medial to the sulcus limitans, but they have a more ventral location, unlike our visceral motor. And so here we have cross sections in the midbrain, pons, and medulla, and notice that there in that vertical column, these nuclei are medial to the sulcus limitans, but they have a more ventral location. In this coronal section, we can see that vertical line going down, and we're going to start with the trigeminal motor nucleus in the kind of like rostral pons area, as that cross section shows. All right, trigeminal motor nucleus. This is located in the pons. We find the water, fourth ventricle. We find the sulcus limitans there, and because of the way that the bending and the flexures of the brainstem during development, sometimes that sulcus limitans in these orientations get moved. There, medial to the sulcus limitans, but a more ventral location, is where we find our trigeminal motor nucleus. This is associated with cranial nerve 5, or trigeminal nerve, but specifically only the V3 or mandibular branch. And this nucleus gives rise to axons that innervate muscles of mastication, muscles that move the mandible. So here we have a picture in the bottom left of a cross-section of this upper pons, the rostral pons, and in lime green we see the trigeminal motor nucleus, the yellow arrow showing. Now let's follow those axons out. They course out laterally in the pons, and then there we see a schematic of our trigeminal nerve. There's the trigeminal ganglion with the V1, V2, and V3 branches. The axon is going in the V3 branches and goes to muscles of mastication like temporalis and masseter, as well as our pterygoids. Okay, move the mandible. But since we're here, let's also just introduce our trigeminal sensory pathways. And so that second line shows chief trigeminal nucleus and tract. This is a sensory cranial nerve nucleus that receives vibratory sensation from our cranial nerve 5 sensory fields. And so if we look down at that yellow arrow showing this now orange nucleus on the lateral side of the sulcus limitans, and there we see a lateral view of the head with sensation from the face showing our V1, V2, and V3 sensory fields. And now we're only going to be taking sensory neurons that sense vibratory sensation, and watch, shing, they all go back through our V1, V2, V3 branches. The cell bodies are in the trigeminal ganglion, which is homologous to dorsal root ganglion, into the chief trigeminal nucleus. And then let's go down to the caudal pons, and we see lateral to the sulcus limitans the spinal trigeminal nucleus and tract, which receives pain and temperature sensation from our cranial nerve 5 fields. And so that's where that nucleus is located. So we see again the sensory fields of the face, but this time we're only dealing with pain and temperature neurons, and they all go back, and that's where they are going to synapse in the spinal trigeminal nucleus. Okay. So the purpose of me just taking that little tangent is to say that here in this upper pons, we can see the sulcus limitans, that red dotted line. Medial to that is the trigeminal motor. Lateral to that is the trigeminal sensory nucleus. All right, so that's trigeminal motor nucleus. Let's now go to the more caudal pons and talk about the facial motor nucleus. All right, so here's a cross-section of the pons. How do we find this nucleus? Find the water. There's our fourth ventricle. Find the sulcus limitans. There's the sulcus limitans. And we're now looking for a nucleus that's medial to that, but out more ventral location. There it is. There's our facial motor nucleus. And these axons from this course around the abducens nucleus prior to exiting the pons, like that. And so you see, and it's actually pretty cool how the axon goes around abducens nucleus and then exits the lateral pons associated with cranial nerve 7, or facial nerve. This is noteworthy because if we have a lesion that disrupts the abducens nerve, often we can knock out muscles of facial expression because of that, because the axon is wrapping around that nucleus. Okay, so the facial motor nucleus gives rise to axons that innervate muscles of facial expression. These are the muscles that are found in the subcutaneous region of the skin. Muscles like our frontalis, that on the forehead, that helps wrinkle your forehead, or orbicularis oculi muscle, the sphincter muscle that closes your eye tight, or the nasalis muscle and associated nasal muscles that helps flare the nostrils, or our zygomaticus major and minor muscles that help you to lift the corner of the mouth to smile, or your orbicularis oris muscle, another sphincter-like muscle that helps you close your mouth or to pucker your lips, as in going for a kiss. And so there we have some, not all, but some significant muscles of facial expression that the facial motor nucleus innervates. The facial motor nucleus or nerve, if it's injured, results in a facial palsy. So the picture on the left is just an illustration showing muscles highlighted, and on the right is a patient that has right facial palsy because of a facial motor nucleus or nerve injury. So the forehead is smooth because the frontalis muscle is not able to contract to wrinkle the forehead. The eye has a difficulty, it can't close the eye, or difficulty closing the eye tight because the orbicularis oculi muscle is denervated. And this is where the eye can become dry, or tears just drain out the side like a leaky eye. The lateral nose droops because the nasalis muscle and associated nasal muscles do not flare the nostril. The zygomaticus muscle isn't there, so the patient has a difficult time smiling. If you say, hey, smile and show me your teeth, you can see the patient's left side of the face, you can see the teeth, but not on the right. What about the orbicularis oris muscle? This is one that helps close, and there's going to be problems closing the mouth. So there's the basic problems, there's a word, I just made that up, feel free to use it. The basic problems if you get a facial motor nucleus or nerve injury. Now, I'm just going to, as I've done a few times, go on a bit of a tangent to just identify something that I'm not going to discuss here, but it's important to know about the facial motor nucleus. Is that this picture shows a patient that has injury to the right facial nerve or right facial motor nucleus, where they have complete paralysis of that side of the face, the ipsilateral side of the face, and they have no wrinkling of the forehead because the frontalis doesn't function. Now, this patient has also some facial palsy, but this is showing injury to the left facial upper motor neuron lesion. So somewhere they call this a supranuclear, above the nucleus, and an upper motor neuron coming from, in her case, the left cerebral cortex and coursing down to synapse in the right facial nucleus. And what happens, though, is you have sparing of the forehead because the forehead, there's a part of the facial nucleus that receives bilateral innervation from upper motor neurons. And so when you hear people say facial palsy with sparing of the forehead or something along those lines, it's the difference between the left, which is a lower motor neuron problem, and the picture on the right, which is usually from something like a stroke. Okay? Just note of that. All right, so we just covered the facial motor nucleus. Now let's go down to the medulla and talk about the nucleus ambiguus, which is now going through the medulla. All right, so here's a cross-section of the medulla, and to find the nucleus ambiguus, we find the water. There's our fourth ventricle. We find the sulcus limitans there, and we find a nucleus that's just medial to the sulcus limitan and a little bit more ventrally located, and there we have it. There's our nucleus ambiguus, and this is associated with cranial nerves 9 and 10. And the axons coming out are going to go and to then innervate palatal muscles to elevate the soft palate, pharyngeal muscles to help us to swallow, and laryngeal muscles for phonation or speaking. Okay. I'll note here that the nucleus ambiguus gives rise primarily to the branchial motor components of the vagus nerve. So if we hit this nucleus, it does have significant clinical results, because if a patient cannot swallow and cannot swallow their own spit and they can't swallow their own food, they're at risk for asphyxiating or even having food go down inside the windpipe and to the trachea, and they have a chance of getting pneumonia or higher risk of choking. So hurting this nucleus is actually very significant in strokes and such. So there's a picture of a posterior lateral view of the larynx, step dissected out to show some laryngeal muscles in orange and laryngeal muscles for phonation. This is what the the nucleus ambiguus helps innervate. If this is injured, they may result with a hoarse voice. It also innervates some palatal muscles, specifically the one highlighted in orange there, which is the eensy weensy teeny weeny levator veli palatini muscle, and this elevates the palate. So injury to the nucleus ambiguus results in the uvula moving away from the side of the lesion or towards the uninjured side. And pharyngeal muscles, and this shows superior, middle, and inferior pharyngeal muscles and the stylopharyngeus muscle. If you hurt the nucleus ambiguus, then you can denervate these pharyngeal muscles on one side and have difficulty in swallowing. Okay, as we mentioned before, and this injury to difficulty swallowing is very significant. Okay, so now in review, we talked about how to find all these nuclei by asking these questions. What level of the brainstem is it? Midbrain, pons, or medulla? If you know what level of brainstem, then you can identify, then you know what nuclei are found at that. Or if you know what the symptoms are, you can then backtrack and say, oh, they have problems moving their eye, but no other problems. Medulla is probably okay, because the midbrain and pons are where those nuclei are located. Where's the water? If you find the cerebral aqueduct or fourth ventricle, if you find that cerebral aqueduct or fourth ventricle, that helps you to then identify where the sulcus limitans is. And if you find that, then you can know if the nucleus is medial to the sulcus limitans, it's motor. If it's lateral, that nucleus is sensory. So brainstem nuclei, clinical correlates. Here we have a picture of cross-section of the midbrain for oculomotor, Ettinger-Westphal, and trochlear nuclei. and what they do and their clinical correlates. And here's a cross-section through the pons and all of the motor nuclei that we find in the pons: trigeminal motor, abducens, facial motor, and superior salivatory nuclei, and what they do and their clinical correlates. And there's a cross-section through the medulla with its nuclei: hypoglossal, nucleus ambiguus, dorsal vagal, and inferior salivatory nuclei, with what those nuclei are responsible in doing and their clinical correlates. And that, my friends, are the brainstem motor nuclei and their clinical correlates in a nutshell.